Welcome to the final episode of our guideline series on pulmonary embolism. Through our episode 1, 2A, and 2B, we have witnessed the transition of our patient, Mrs. Mehta, from an emergency room to thrombolysis for her pulmonary embolism. And throughout this, we have followed the 2026 AHA, ACC, ACCP, and CHEST guidelines on acute pulmonary embolism in adults. We proceed with the last episode where we are looking at advanced therapies, discharge decisions, and recurrence prevention. So let's discuss what comes next after thrombolysis and how we can follow these patients. So, when we started our episode 1, we saw that Mrs. Mehta came to the emergency. She had a diagnosis of pulmonary embolism based on the prediction tools. We then categorized her for her severity based on the latest guideline discriminations. She was then observed and additional testing followed, which changed her categorization, and thrombolysis was planned. What are our options now? What if she is a contraindication to systemic thrombolysis? What options remain and are they justified? So today's roadmap includes one part where we will be talking about advanced reperfusion. We'll be talking about three major techniques: the catheter-directed thrombolysis, mechanical thrombectomy, and surgical embolectomy. And in the second part of this video, we'll be talking about the long-term care, deciding on anticoagulation, duration, how to follow up, what to see in follow-up, and how to ensure that the patient hasn't developed CTEPH or chronic thromboembolic pulmonary hypertension. So, in the final episode, we are reviewing the advanced techniques during hospitalization and follow-up care. So let's move from acute rescue to recovery and management. So, as I said in my introduction, the catheter-directed interventions, mechanical thrombectomy, and surgical pulmonary embolectomy constitute the advanced reperfusion techniques. Most patients with acute pulmonary embolism will improve with anticoagulation, and selected high-risk patients will also respond to systemic thrombolysis as discussed in the previous video. A very small group of critically ill people who cannot receive thrombolysis because of bleeding risk or are deteriorating on medical management can be managed with these advanced reperfusion strategies. The guideline discusses these three options in a structured manner. It describes the three major strategies and tells us how the choice depends on the patient's clinical condition, the risk of bleeding, the anatomical considerations, and importantly, the local expertise and availability at your center. These therapies are not competitors, they are complementary tools selected for the right patient at the right time. The first table that actually gives us a summary of these advanced therapy recommendations has beautifully shown how various recommendations come with their own uncertainties based on the level of evidence that we have to these strategies. If we look at patients with class A to C1 P risk outcome category as discussed in the previous videos, then most of these patients will have a harm or no benefit with systemic lysis and advanced reperfusion techniques. So to say, patients in the milder group till the C1 outcome category will not require thrombolysis or any advanced technique. For patients moving on to category class C2, here also both systemic thrombolysis and advanced reperfusion techniques can be harmful. So the grade 3 recommendation for harm comes directly to systemic thrombolysis, and for the advanced reperfusion techniques there is low evidence or no benefit detected. As the patient goes on to his severe profile, again there is an unclear role of thrombolysis and advanced reperfusion techniques. So the data is not very robust still. But which is the category where we may consider these advanced techniques? It includes patients in D1 to D2 class. And these patients, although the recommendations are based mostly on the expert opinions and have low evidence, these may be considered in the right group. As we move on further to more complex patients, patients on ECMO, patients who have refractory hypertension, you may not be able to perform these advanced reperfusion techniques, and so the effect is really unclear. So when you look at these tables which have been provided by the guidelines, they've given specific indications where you may consider one technique over the other. Look at this table which shows intervention based on patients having a floating right atrial or right ventricular clot in transit. It clearly says that there is a 2A level of recommendation but a limited evidence which shows that patients from category C3 to E2, if they have a free floating clot, you can use the advanced therapies or anticoagulation because that may have less systemic complications and we know what we are targeting. If you look at those patients who are in C2 to D2 categories, which are basically the category which is a little less severe than the one here and without contraindications to thrombolysis, where you are considering advanced therapy, you could use catheter-directed or mechanical thrombectomy over the other, but the effect is uncertain because there may still be some level of major bleeding and mortality. So the usefulness of these therapies is still uncertain. So if we are going down the cascade of severity, we know that we are targeting clots in transit, or we can see free floating clots. There may be more indication of using a particular technique like mechanical thrombectomy. Otherwise, patients without contraindications to thrombolysis, would you choose advanced therapy? That is uncertain. Historically, variable strategies have been considered for management, and they have said that in almost 2 to 4% of patients in a CT or in the echo, you may actually see floating clots, and those will be the patients where you can employ these techniques better. We don't have high quality comparative data addressing this clinical situation, and there is also less likely that this data will emerge in the near future. So, patients who are being actually enrolled in these large cardiovascular outcome trials, which are looking at catheter directed or mechanical thrombectomy against anticoagulation, they are less of these trials. And here, only patients where you deem appropriate that a catheter directed therapy may influence the outcome would be the one where the operator is experienced to do it, the clot location is anatomically favorable, and there is a perceived urgency of the patient's condition to perform such a maneuver. There have been certain retrospective analysis mentioned in the guideline where they've looked at the PERT consortium registry and they've shown that there is an independent association between clot in transit and mortality. And in such a case, you may want to manage the clot in transit with the methods that are depicted here. Also, they have seen that if you look at patients in the peerless trial, they mentioned that patients C2 to D2 category, if you compare MT or catheter directed therapy, there have been no significant difference in major bleeding or mortality. So it's really a decision based on your clinical picture. What is this catheter directed thrombolysis that we are talking about? This basically, unlike systemic thrombolysis, is a technique where we are delivering fibrinolytic therapy directly to the pulmonary arteries through this catheter. And why we are doing this? The objective is to achieve effective clot dissolution using a lesser dose of a thrombolytic because you're using a catheter to direct it. So you are trying to avoid systemic bleeding exposure or systemic consequences, and you're using a more directed therapy. Now, this guideline clearly mentions where you would prefer this technique, as I said, and this is the table that gives us all the answers. There is a 2A level of recommendation that in patients with acute PE in category E1, a catheter directed thrombolysis plus anticoagulation is reasonable to prevent further deterioration and mortality. So, category E1, you can do a catheter directed thrombolysis if you have an anatomical reason to do it. There's also category grade 2B recommendation, where the level of evidence is not robust, that in category D1 to D2, so less severe patients where you are considering the advanced therapy, you may consider in some patients anticoagulation plus catheter directed therapy. As we move further up the ladder, so patients who are relatively moderate, the category C2 to 3, here, if you look at the benefit of catheter directed therapy plus anticoagulation compared to only anticoagulation, the evidence is unclear. So, in these patients, you may not actually be preferring to do this. And if you look at categories D1 to E1, where you are considering thrombolysis, again, if you look at the efficacy and long term survival, then you think that this patient may have more systemic side effects, then you may consider these therapies, but grade 2B recommendation. There is no benefit of doing this maneuver in patients of acute PE who are undergoing CDL. There's no benefit of reduced thrombolytic dose of less than 5 milligram because it's not recommended to use this over a standard dose of 5 to 10. So if you are doing catheter directed thrombolysis, there is no benefit, no recommendation. Then grade 3 recommendation of no benefit in patients with acute PE who are undergoing catheter directed thrombolysis, no benefit of reduced thrombolytic dose less than 5 milligram alteplase over a standard dose. So you would use the standard dose and not try to reduce the dose. Again, no benefit in patients with category A to C1. You will not do catheter directed thrombolysis in these patients. So patients who are C1 and above, they have a low risk of clinical deterioration. So there's no need to do a reperfusion strategy like this. But in other patients, if you look at catheter directed thrombolysis plus anticoagulation, there will be a higher risk of major bleeding, but we don't have much evidence to favor one over the other. This is how it looks in case you're wondering what is done. So, in catheter directed thrombolysis, which is widely available, a catheter is used and the anticoagulant is directly delivered into the pulmonary artery. And this is in favor of mechanical thrombectomy. Basically, patients with hemodynamic deterioration, even with the need for ECMO, this is more favorable. Patients with bleeding risk, patients with high thrombus burden. This is not an image taken from the guideline, please note that. However, I've included it for better understanding of what we are talking about. So, usually, what we understand is that patients in P category E1 are generally deemed to require advanced therapies beyond anticoagulation, and one of these can be chosen. There has been a systematic review and meta analysis of more than 500 patients, almost 600 patients, retrospectively studied, and they've noted that of the category E1 patients who required this procedure, 67% patients had improved survival to discharge. And if you use it with anticoagulation systemically, it will have a higher risk of major bleeding. So that one has to be careful of. There have also been certain trials mentioned in the guideline, like the Plethora trial, which has demonstrated that thrombolysis plus anticoagulation in category C3 to D2 was more efficacious. So patients may not require advanced therapies always. That's the message. But in category E1, one may have to consider these. What is the dose of alteplase in such studies? The guideline mentions that there have been a range of doses from 4 milligram to 24 milligram total over 2 to 24 hours. The reduced dose is defined as less than 5 milligram and the standard dose is 5 to 10. Catheter-directed thrombolysis has not been studied in patients between category A to C1 and again is not indicated. So let's distinguish between these. Both approaches are catheter based, catheter directed thrombolysis and mechanical thrombectomy, but they are fundamentally different. Here we are relying on targeted fibrinolysis, and mechanical thrombectomy we are using our tools to remove a thrombus mechanically. This guideline deliberately avoids recommending one over the other. It stresses individualized decision making and has to be done in centers with the expertise to do this. So, coming back to my patient, Mrs. Mehta. Imagine she had undergone a major surgery and her systemic thrombolysis was not possible, or she had been given systemic thrombolysis but she continued to deteriorate. This is precisely the type of scenario where an MDD regarding an advanced reperfusion will become important, and maybe catheter directed therapy could be considered. Coming to the table regarding mechanical thrombectomy. Now, mechanical thrombectomy we've seen represents a different philosophy. We are not dissolving the thrombus pharmacologically. We are using a dedicated catheter system to physically remove the clot from the pulmonary artery. And again, when thrombolytics are contraindicated or when there's a big burden of clot and we want to have a rapid reduction in clot burden, this may be desired. It is a percutaneous therapy and the catheter is directed to the location of the indwelling thrombus here. It's commonly performed through femoral vein, and the objective is simple: extract the thrombus directly from the pulmonary circulation and bring it outside. So there are devices which have been used, there have been tools which have been used, there have been a lot of techniques that have been discussed in the guideline paper, which include large, moderate, small bore suction thrombectomy, clot fragmentation, rheolysis, maceration, extirpation, or combined approaches. But we are trying to have an immediate removal of the thrombus and expedite the symptoms relief for our patient. And because it's percutaneous, we are not using a lytic medication. We are not requiring indwelling catheters and long ICU stays, and we can remove thrombuses which are even old. What does the guideline say about this? In the recommendations, most are 2A and 2B, except there's a grade 3 recommendation of no benefit in again categories A to C1, like we said earlier. Which are the category where it may benefit? Category E1. It's reasonable to choose mechanical thrombectomy plus anticoagulation over anticoagulation alone to prevent further clinical decompensation in this category. And again, in categories D1 to D2, where you are thinking of this advanced therapy, again, when you're using it, you may consider it over anticoagulation alone. What about the other milder categories? Just like CDL, the benefit of mechanical thrombectomy plus anticoagulation compared with only anticoagulation is unclear. So this is the gray zone. And in patients with category D to E1, again, the recommendation is not there. They say that patients in whom you are planning advanced therapy, the efficacy of mechanical thrombectomy to reduce clinical deterioration, fatal, non-fatal, improved survival is unclear. So this is also a group where you will be in gray zone. They have mentioned one trial called the FLAME trial, flow trigger for acute massive pulmonary embolism study, where they've looked at category E1 patients, 115 of those patients who underwent mechanical thrombectomy or other therapies, and they found that the endpoint of reduction in all cause mortality was 17%. So again, the evidence is not very rich, but yes, they did see a average post procedure mean PA pressure decline significant compared to pre procedure, and in similarly designed studies like extract PE study, they've also seen significant reduction in the mean RV to LV ratio. They've seen a rate of major bleeding as low as 1%. And so this is one option which is available. Coming to the third advanced reperfusion option, which is surgical pulmonary embolectomy. Now, unlike catheter based therapy, this is surgical. So, it will be an open surgery. We are trying to remove the thrombus directly from the pulmonary artery. It's invasive, so you can only do it in a carefully selected patient group. But look at the level of recommendations. No benefit A to C3, and even on E2, in patients with acute PE category E2, not on mechanical circulatory support, surgical embolectomy is not recommended over other therapies. So, really difficult to choose a patient for this procedure. Coming to another aspect, which is IVC filters. I remember IVC filters were talked about a lot in the past for PE patients, and this guideline has really given us a lot of clarity on them. Now, IVC filters are sometimes perceived as an alternative to anticoagulation, but the guideline makes it very clear that their role is limited. They have to be reserved for a carefully selected group, and they should not be used routinely in patients who can get anticoagulation. And that's the message you need to remember. What do? They filter mechanically, they filter and mechanically intercept venous thrombi and prevent them from going to the pulmonary circulation. So, by percutaneous techniques, they actually are easy to apply, and they have two forms, the permanent and retrievable forms. Now, the indication of IVC filter placement is that scenario where anticoagulant therapy is absolutely contraindicated and there is an instance of recurrent PE despite the optimal anticoagulation that you're giving. So there are potential indications like there is a free floating thrombus, and their anticoagulation is an issue, but they are under scrutiny and the scope of these is still evolving. Remember, they've mentioned about concept of retrievable IVC filters, and they've said that that would always be preferred over permanent filters, because we need short-term protection which they can give. They've mentioned in the guideline about certain trials like the pre-pick trial that has shown that IVC filters can lead to very high rate of DVT and IVC thrombosis over time. So what does this table show? We start from the recommendation of harm, and it clearly shows that in patients who are therapeutically anticoagulated, routine placement will be of harm. So that's a very high level of evidence, which is A, and recommendation grade 3. Now, what is the recommendation level 1? In patients with acute PE who cannot tolerate anticoagulation but IVC filter is deemed necessary, you will put retrievable filters over permanent to reduce short-term incidence of recurrent PE. Another level 1 recommendation is that when you are using retrievable filters, the retrieval of this filter should be as soon as possible, as soon as the risk of PE has sufficiently decreased and anticoagulation has been tolerated. That's very important. One, put retrievable, and two, take them out as soon as possible. The grade 2 recommendation is that if your patients cannot tolerate anticoagulation on long term, then you may consider these filters to reduce short term incidences. And in patients with indwelling IVC filters, a structured follow-up program is very, very reasonable. Then when you're going higher up the categories D and E, with advanced interventions, they say you don't have much evidence or uncertainty of evidence for IVC filters to help you in the short run. So here you may do the advanced reperfusion. And they also mention that in patients with recurrent PE despite therapeutic anticoagulation in category B to E, you may consider these for short term benefits. So, that is the stand on IVC filters. Short term, when really indicated, retrievable, and take it out as soon as possible. So, IVC filters are not a substitute for anticoagulation, used in selected people, and retrieve them once no longer needed. This chart has not been sourced from the guideline, but I have kind of made this to make things a little more easier and for us to revise what we have done as of now. One of the most important messages that are coming out of this guideline is there's no single best reperfusion strategy for every patient, and you have to look at the clinical picture. So, see your high risk PE patient. Is systemic thrombolysis appropriate? If yes, then that's your first choice. If it's not appropriate or patient is deteriorating despite on that, then you have these three options which have to be individualized based on where you are and what you are trying to achieve. And this is the time where the PERT group will help you take the decisions. All decisions regarding advanced reperfusion therapies should rarely be made by a single physician. It is a team effort, and if you have a pulmonary embolism response team, which we discussed in our first video, then use that team to help you understand the patient's condition. Use the cardiac surgeon, use the interventional radiologist, use the non interventional cardiologist, and the vascular surgeon, and the whole team to see whether this patient is a candidate for that advanced therapy. So, let's do a quick case recap. Fortunately, Mrs. Mehta was better after her thrombolysis and she did not require any advanced therapy. Her BP improved, her RV function recovered, her oxygen requirement came down, and now she's ready for discharge. But whenever our patient is ready for discharge, a new set of important questions begins, and this brings me to the part B of my today's video. Now, many clinicians think that management of PE will end when the patient leaves the ICU, but in reality, the long term management is very, very important. Let's see how to choose that. The acute crisis is over, but the treatment is far from over. It has just begun for our patient. So, which anticoagulation should we use? For how long? And how should she be followed up? And will she develop any chronic complications? That's what we're going to answer. So let's look at a scenario that your patient is now coming back, walking into your outpatient clinic. Will you wait for 3 months for her to come back? No, you will not. But you will have to keep taking decisions, even up to 3 months and beyond for this patient. So a post PE follow up requires optimization of anticoagulation, deciding which anticoagulation, evaluating symptoms, trying to improve their quality of life, screening for CTEPH, and detecting recurrence. So, objectives are preventing recurrence, evaluating symptoms, and looking at both physical and psychological well being of your patient. Now, since Mrs. Mehta has recovered and is attending her first follow up, there are certain things that one has to look at. The 2026 AHA guideline emphasized that the follow up has to be very, very structured, and the goal of the follow up is also to see whether there are recurrence risk factors. We have to ensure that in patients with acute PE who did not have an initial identifiable risk factor, an age appropriate cancer screening is obtained. That's very important. Grade 1 with level A recommendations. In patients without a major reversible risk factor, such as a surgery, for acute PE who have a family history of thrombosis or are less than 55, it's very important that you do thrombophilia testing. And this are important to change your management decisions and discussions. Another evidence of which is level A, but and the recommendation says no benefit is that in patients with acute PE, a routine imaging with CT or PET is not recommended to diagnose undetected cancer. Such an important message. You see your patient and you want to rule out cancer, that's the first level of recommendation, very, very important. But would you do a whole body PET scan to see whether this patient has any cancer anywhere in the body? There is no benefit of doing that, and the guideline discourages us from doing this. Since we know that pregnancy, hormonal therapy, and contraception is important risk factors, especially in females, it's important to understand this level 1 recommendation, which says that patients of childbearing potential with acute PE have to be counseled about contraception and anticoagulation options in the event that they become pregnant. Another grade 2 recommendation is that if your patient has experienced PE and become pregnant, the team again has to look at the thrombotic complications because you want to minimize complications in the pregnancy. And for patients using anticoagulant therapy for treatment or prevention of PE who are at risk of abnormal uterine bleeding, you have to discuss the alternates to anticoagulation, you have to involve the gynec, and that's really important. And for patients who are considering estrogen containing hormone therapy, continuation or initiation of hormone therapy might be considered if there is a risk benefit ratio. Otherwise, you know that this hormonal therapy will increase the risk of recurrent PE. So, this is specific to the female population. When should these patients be reviewed in general is another important aspect. Now, the guideline recommends that these patients should undergo a clinical follow up within 1 to 3 months after the acute event. Exact timing depends on the severity of the presentation, the complexity of the management, and at every follow up visit, you have to have a comprehensive clinical assessment. Recovery will not be just an absence of recurrent embolism, it would be the symptoms, the exercise tolerance, the adherence to the therapy you sent him home on, bleeding complications, requirement of oxygen, functional recovery, and complaints of persistent dyspnea. So, all of these are recommendations of level 1, which says that in a patient with acute PE, follow up is preferred within the first week of discharge. Here you will give him education, you will address anticoagulation therapy barriers, you will ensure adherence and detect bleeding complications. Then, after the first week, a visit at or before 3 months to discuss how further along you will need anticoagulation and review needs for testings and assess persistent symptoms. Then, once this patient are coming, you have to continue to bring them to your clinic for at least 1 year and do functional assessment, symptom evaluation at every visit to rule out CTEPH and other causes of dyspnea. Now, in patients with a history of PE who remain on anticoagulation for this extended phase beyond the first 3 months, 3 to 6 months, periodic reassessment of the risks and benefits of continuing anticoagulation is again very, very important. And the use of general or disease specific questionnaires can be done at follow ups, and it's also reasonable to have special PE clinics. And for patients who are symptomatic beyond 3 to 6 months, you should obtain other objective tests like the 6-minute walk test, the shuttle test, and so on for a comprehensive evaluation. So, it's not just about having symptoms again, it's about the total improvement and recovery. So, if Mrs. Mehta was to be seen now after the first week, now at her 3-month visit, we have to ask her, how are your symptoms? Are you still breathless? Do you have any chest pain? Are you able to tolerate exercise, walk in your house, do your activities of daily living? Are you continuing the anticoagulation we sent you home on? And do you have any persistent dyspnea? So, the timeline of follow up is anything from 48 hours to 7 days, less than 3 months, then every visit for a year, and then extended anticoagulation reassessment at every visit. Now, Mrs. Mehta is fine at 3 months and she wants to travel to meet her daughter abroad. What are the recommendations that the guideline gives? Now, persistent breathlessness after PE is very, very common. And while most patients will stabilize with rehab, we have to be vigilant for chronic thromboembolic disease. So, there is a two-way level of recommendation with a good level of evidence that in patients recovering from acute PE, you should encourage them to ambulate early rather than bed rest because we don't want newer thrombi. Then, in patients with history of PE and the use of compression stockings has to be recommended for long haul flights, more than 5 hours. That way, the risk of DVT will be less. So, Mrs. Mehta can be asked to use compression stockings if she's flying long haul. In patients with a history of PE related to travel or immobility who are not currently receiving anticoagulation, you have to use a one-time prophylactic dose of an oral anticoagulant or a parenteral low molecular weight heparin on the day of the long haul to reduce the risk. So if this patient has had a history of PE which happened because of the last time she flew and now she's going for a flight again, or she was immobile because of a fracture and now she has to stay in her seat for a long time again, then it is reasonable that you give her a one time prophylactic anticoagulant, oral or parenteral, before that travel. Grade 2B recommendation. And for patients recovering from acute PE in class category C2 to E, it may be reasonable to restrict their long haul travel for 4 weeks after initiation of treatment or when the symptoms are resolved. So, if the patient comes to you within a month and asks you whether they can fly, that the answer might be no. But if, like for my patient, it's 3 months, you may allow. So, what are the recommendations for anticoagulation therapy by recurrence risk in the study? So the guidelines mention that first acute PE with no major reversible risk factor, you should continue anticoagulation beyond the initial phase 3 to 6 months to an extended treatment phase. That will be beneficial to prevent recurrent VTE. So no major reversible risk factors. We didn't know why it happened. Try and give an extended phase beyond the initial treatment of 3 to 6 months. Secondly, in patients with first PE, because of a risk factor which was reversible, say a surgery, you can stop anticoagulation at the end of the initial treatment phase. So, initial 3 to 6 months, and you stop the anticoagulant rather than giving it extended. Another level 1 recommendation says that if the patient had first PE, but the risk factor is persistent, say they have a cancer, continuing the anticoagulation at the initial treatment phase into the extended phase is again reasonable. For patients with PE who are offered anticoagulation beyond the initial phase into extended phase, we should prefer oral anticoagulation. We should prefer DOACs unless contraindicated over a VKA to reduce the risk of bleeding. That's another recommendation. And it also says that if the patient has cancer and you're giving extended treatment, again, either a DOAC or a low molecular weight heparin is recommended over a VK. So over warfarin to reduce the risk of recurrent VTE. For patients with PE without cancer and you're giving an extended treatment phase but they cannot take DOAC, that is the time you can give a VKA, which is better than giving aspirin or no therapy. And for patients with PE who are offered anticoagulation into the extended phase, you can actually give them half dose of apixaban or rivaroxaban in the extended phase to reduce bleeding. Now, the grade 2 recommendation is that if the patient had first PE because of a minor reversible risk factor, you can take a shared decision about stopping the anticoagulation at the end of the initial treatment versus continuing it. And those who are actually offered extended phase but they have a contraindication or they don't want to take anticoagulation, then only in that case you can choose a low dose aspirin over no therapy. So this is very, very strong evidence, and I think this table gives us a lot of information on what to do with a lot of clarity. So let me summarize it. If there's a major reversible risk factor such as a surgery with general anesthesia or hospitalization for acute illness or a cesarean or a lower limb fracture and the patient is improved, you may not give them extended phase. For minor reversible risk factors, for a short surgery and PE, for out of hospital acute medical illness, you may not give them extended phase. But for persistent risk factors like active cancer or autoimmune disease, you may have to do that. So for recurrent PE, grade 1 recommendation says that if your patient had PE history and now has come with new symptoms and signs which are telling you recurrent PE or breakthrough PE, you have to go on and do a CTPA or a VQ scan, number 1. Number 2, if they have a document recurrent PE despite being on anticoagulation, now you should look at those clinical and pharmacological factors which cause this recurrent PE because you need to modify them. Grade 2 recommendation says that if they had a recurrent PE but they were taking their therapy very religiously, you should now consider changing the therapy to an alternate drug class and not continuing the same, which is very obvious. The fourth recommendation is that if they have a documented recurrent PE, they were adherent to a reduced dose DOAC, now you should give them a full dose of anticoagulation. And patients with cancer and recurrent PE, despite being anticoagulated with low molecular weight heparin, You should escalate the dose of low molecular weight heparin by 20 to 25% to prevent recurrent PE. Very, very clear, beautiful table. If your patient is persistently symptomatic after acute PE, what would you do? The first level of recommendation is that if your patient is continuing to have dyspnea and functional limitation, it's been more than 3 months, you've kept him on anticoagulation, now is the time to look for chronic thromboembolic pulmonary disease. So, more than 3 months, still dyspneic on anticoagulation, probably the complication has started. For patients undergoing a diagnostic evaluation for this, what would you do? You would do a transthoracic echo and a lung perfusion scan, single photon emission CT SPECT or SPECT CT over just doing an echo alone. So, very clearly saying that you need to do both a transthoracic echo and an imaging, whether it is CT SPECT, whether it's VQ or SPECT CT, you have to do that. For patients undergoing diagnostic evaluation, even a cardiopulmonary exercise testing is reasonable to exclude CTPD. So you can add it to your algorithm, but there will be no benefit in case patient has a history of acute PE who has resolution of symptoms, low suspicion of CTPD, to just do a routine follow-up CTPA to rule out thrombus resolution. In that case, it's not indicated, only if your patient is symptomatic. The recommendation says that patients being evaluated for CTPD should continue their anticoagulation until the evaluation is complete so that they don't have a new embolus. And for patients where you've now excluded this but they have ongoing dyspnea and impairment more than 3 months after an acute PE, you should start a rehab. You exclude chronic thromboembolic pulmonary disease and start a rehab. And for patients with the diagnosed CTPD with pulmonary hypertension, we need to refer them to somebody who can manage this together. And for select patients who don't have pulmonary hypertension, again, you should look at the center with expertise. So, patients can present with a constellation of clinical syndromes after an acute PE. Almost half of the patients may stay symptomatic and have no vascular complications after the PE, and it's common to have symptoms even beyond 3 months. The other half of the patients may be the ones which come under the umbrella of chronic thromboembolic pulmonary disease, and they include patients with residual pulmonary vascular obstruction. They include patients who come under pulmonary hypertension or chronic thromboembolic pulmonary hypertension. And they may also have patients who have symptoms but without the pulmonary hypertension component. Let's try and summarize based on this beautiful flowchart given in the guideline how to evaluate patients having ongoing symptoms after acute PE. You see to the right that there are certain legends given, and the ones marked with green are the ones with recommendation grade 1, and the others are mostly with grade 2A. So here we are talking about patients who have come to you and more than 3 months after the acute PE, they are still symptomatic, they're still breathless, they may have chest discomfort and decreased functional tolerance. When that happens and your patient comes to you, you would do both TTE and a VQ or SPEC CT. That's the recommendation. So you may choose the path where you're doing both. And if the lung perfusion is normal and CTPD is excluded, you may give your patient some pulmonary rehab. Or you may choose a path where you may perform a non invasive test first, and that would be a cardiopulmonary exercise test. If the cardiopulmonary exercise test shows that there is a PVD limitation, then yes, you will now go to the invasive route, do a TTE and a scan, and then again decide three factors. First, is the lung perfusion normal and you've excluded chronic thromboembolic pulmonary disease, or there is an abnormal lung perfusion and a low probability echo where the possibility still stays, or there is an abnormal lung perfusion and a high probability echo, and it's very likely that your patient has developed the other half of the clinical syndrome, which is likely CTPD. Now, if it is possible that the probability is low but yet exists, then in this group of patient, you again think of performing a non-invasive CPED and confirming the PVD limitation. And if that's the case and he has pulmonary hypertension, then you would do a pulmonary angiogram, a right heart catheter, or an exercise tolerance test, or you may do an extensive evaluation for this patient and decide the further course. If there was no limitation, then obviously you would exclude CTPD. But for patients where it was very likely that you have a chronic thromboembolic pulmonary disease, again, we need a referral or integration of multiple specialities and include assessment with pulmonary angio, right heart catheter with or without exercise, and evaluation. But if your initial CPT did exclude PVD, you can actually stop right there and not follow up the patient in case he's asymptomatic. So essentially there are two things that have been given in this flowchart, and they are across the span on the flowchart. It's one that either you go the non-invasive way and do a cardiopulmonary exercise test and follow it with imaging and TT, or you go directly to both of it depending on your patient, what was the risk category of this patient, how much is the symptom. And if it is positive for chronic thromboembolic pulmonary disease with or without hypertension, if it's with hypertension, you definitely have to do an angiogram, a right heart catheter with and without exercise test. And if it is without pulmonary hypertension, then also you would consider doing further testing and following up your patient. If you exclude chronic thromboembolic pulmonary disease, then you can follow your patient and give him pulmonary rehab. So, coming to summarizing what we've seen, so which anticoagulant have they recommended in the guideline for long term? The preferred are the oral anticoagulants. For patients who continue anticoagulation beyond the initial phase, you would reduce them to half dosage if intended. Then, for patients who have cancer associated PE, you would again recommend them over vitamin K antagonists, and you can also choose to give a low molecular weight heparin. Only if they cannot receive a DOAC and VK is not possible, then you may consider aspirin over no therapy. For extended dose, half dose apixaban or rivaroxaban is recommended. And again, the major reversible risk factors, they may not require extended anticoagulation, and here you can stop anticoagulation in the initial 3 to 6 months. Only if there's a persistent risk factor, you may have to extend them beyond the initial phase. Have they recommended indefinite anticoagulation? No, not automatically. They have repeatedly emphasized in the guideline that periodic reassessment of benefit versus bleeding risk has to be done in the extended phase, and they've recommended reassessing patients on multiple factors rather than giving lifelong anticoagulant therapy without a review. This is very important. So, quick summary before we end. Major reversible risk factor, stop anticoagulation in 3 to 6 months. Minor reversible risk factor, take a decision and stop if possible. No major reversible risk factor and an unprovoked PE, give them extended if possible. Persistent risk factor, definitely give them extended. Preferred drugs, oral drugs. If extended therapy is chosen, reduce their dose and see for recurrence again. With that, I conclude this very exhaustive video on advanced therapies and follow-up care. I hope It was easy to understand, and you've got a glimpse of what the guideline says. They've given a lot of data to support the recommendations that they've made, which is beyond the scope of a video, a talk. And so, if you want further insights, I recommend looking at the synopsis portion and supportive evidence, which is given under each table. So, with that, I conclude this series, and I hope to hear from you on what topics you would like to hear again. Till then, happy reading. Enjoy reading about more and more topics in pulmonology, and we'll meet again on Pulmonology Read Aloud.